Hello, my name is Alicia Bruce. I'm a registered dietitian and I'll be presenting a case study on enteral nutrition. The case I will be presenting is on a 63-year-old male. He was found unconscious and unresponsive at home. At that time, he was sent to another facility's ER where he was intubated and sedated. He was then transferred to my facility for a higher level of care. His past medical history included hypertension, hyperlipidemia, GERD, and quadriplegia. The patient has been a quadriplegic for over 30 years following a work accident. A consult was received from our critical care physician for a ventilated patient. His anthropometrics are as follows: height of 6'4", weight of 107.7 kilograms, BMI of 28.9, ideal body weight of 92 kilograms, which puts his percent ideal body weight at 117%. These are his initial labs. His sodium chloride, BUN, creatinine, and calcium were all low, while his glucose and bilirubin were high. Respiratory failure and sepsis were the cause of these abnormal labs. IV fluids were started, antibiotics, and pressors. The Penn State formula was used to determine the patient's calorie needs, which put him at 2,105 calories per day. Protein needs, we did 1.5 to 2.0, which gave him 162 to 215, and fluid 1 milliliter per kcal or per the MD, which is typically what we do in CCU. The PES for his initial assessment was increased nutrient needs related to increased nutrient demand, as evidenced by critically ill mechanical ventilation. During CCU rounds, our physicians informed us that the patient was going to get extubated within the hour, so my recommendations were to advance the diet slowly, starting with clear liquids, transitioning to full liquids, then cardiac, as able to tolerate safely. The patient was extubated and stable enough to transfer to our telemetry unit. He remained in PO during that time because he was on continuous BiPAP and needed a clearance from speech therapy. They did evaluate him and recommended a dental soft diet with thin liquids. A few days later, the patient did have a choking episode and aspirated. He was in PO at that time. A few days later, he ended up transferring back to the CCU due to his respiratory status worsening and needing continuous AVAPs. The PES statement changed at that time to inadequate oral intake related to difficulty swallowing, as evidenced by NPO status post-aspiration. The intervention was if we were unable to advance the diet safely to consider nutrition support. Since he was no longer on the vent, I did update his calorie needs to the Mifflin-St. Jeor equation times the 1.2 activity factor, which gave him 2,355 calories. His protein needs were from 0.8 to 1 gram per kilogram, which gave him 85 to 107, and the 1 ml per kcal of fluid. We were reconsulted a few days later because the patient was getting a PEG. The PEG was placed because he would need long-term nutrition. He was only meeting 25% of his needs by mouth. We went with a polymeric formula, Gevity, because the patient had no medical history for needing a specialized formula. Our facility uses 1.5 kcal formulas, and so that's why I went with that. His goal rate was 65 milliliters per hour of continuous for 24 hours. If able to consume 50% or greater, we would reduce that rate to 30. The reason the patient did need that PEG was because of that aspiration. So treatment for aspiration pneumonia is a course of antibiotics, which he was started on vancomycin and Zosyn. Prevention for further aspiration is to work with speech therapy and making sure that we kept the head of his bed greater than 30 to 45 degrees. These are the recommendations for the Gevity 1.5 at the goal rate of 65 milliliters. It was providing 99% of his calories, 93 to 117% of his protein, 50% of his fluid needs, which we added a free water flush of 195 milliliters every 4 hours, and 156% of the DRIs. He was not consuming much PO intake because he didn't like the dental soft diet, so speech advanced to regular with the understanding he would perform the necessary precautions to prevent aspiration. We did start his tube feeding at 10 milliliters per hour and advanced it 5 to 10 milliliters every 3 to 4 hours as tolerated, which initially he tolerated well. At the follow-up, patient reported an increase in nausea, bloating, and gas. He stated that he was lactose intolerant, which we had no documentation of or report from the patient before. We did inform him that the formula he was on would be okay for lactose intolerant individuals, but if he was more comfortable trying our plant-based formula, that we could trial that, and he was okay with that. Labs continued to improve during his admit. These are the recommendations for the Kate Farms, which is our plant-based formula. The recommended goal rate was at 70 milliliters per hour for 24 hours continuous. This would provide him 100% of his calorie needs, 102 to 128% of his protein needs, and 51% of his fluid needs. We did not do a free water flush because he was drinking adequately, but recommended 30 milliliters every 4 hours per Aspen recommendations for 2 patency. In summary, the patient was admitted to critical care after being intubated. After a short-term intubation, he was extubated and transferred to the telemetry unit. He did have an episode of choking, and as respiratory status worsened, was sent back to the CCU. We eventually placed a PEG, which we started with a polymeric formula, and after not tolerating, we changed to a plant-based formula. We were unable to monitor weight changes because the patient had ordered a specialized bed and it did not have a scale on it. And due to his quadriplegia, the staff was not comfortable weighing him any other way. He tolerated the feeds well, did not want bolus feedings, and preferred to do continuous, which was approved by the DME company and his insurance. In summary, these were his labs. Started off with a lot of abnormal labs and ended up with just a low sodium, very minimally, and the doctors were okay with sending him home with that. These are timelines and my citations. Thank you very much.